Pakistan last year. So thanks again. Just to, obviously, it is a difficult time. That's why, but we are on the web lessons. While there are many advantages to give a talk on the web, but there are some disadvantages as well. As a presenter, cannot see the audience, but don't worry, I will be watching all of you because there are hidden cameras in this link we sent to you. So I will be watching who is sleeping and getting bored. Sorry, just kidding. So I will be talking on the basics and the norms of the neonatal ECGs, but I will also give you some flavor of the abnormal ECGs. I hope everyone can hear me.
Yes, sir, you are.
Okay, thank you. So anyone can interrupt me during the talk if there are any questions. Just see why this. Okay, so what is the ECG basically? The ECG is the electrical activity of the cardiac cycle, which is generated by the specialized electrical wiring system of the heart called cardiac conduction system. The cardiac conduction system consists of the sinoatrial node, which is normally located at the upper part of the right atrium near the SVC, and then it goes to the AV node, then the AV node bundle of His, and there are two branches, right and left bundle branches, and then the left anterior fasciculus, and then the Purkinje fiber. So that's what the conduction system consists of. The conduction system develops during fetal life when the heart is developed. Now, each event basically, when it happens right from there or there, wherever, it creates a different waveforms. So if we look at that, the SA node, when the electrical activity happens at the SA node, it sends the signals to the right atrium and then to the left atrium. So it causes the atrial depolarization. With the atrial depolarization, the P wave is generated. And then there is a little bit of AV delay that is due to the atrial contraction. And then the ventricular depolarization, when the electrical activity reaches down there, the ventricular depolarization starts at the apex level. And with the ventricular depolarization, the QRS complex is generated. When the ventricular depolarization is complete, that is a segment there, and with the ventricular repolarization, the T wave is generated. So that's what the normal waveforms you will see with the conduction system. So obviously it depends on the condition or the underlying condition or the age. So all the complexes will be different, but nearly their shape will be like that. So what are the differences basically between the neonatal and the adult or the older children? So what are the differences in terms of the ECGs? There are some anatomical differences because if we know during the fetal circulation, basically the right ventricle is mainly pumping and giving the more blood to the lower part of the body, and the left ventricle is just only pumping to the blood to the head and neck vessels. So there is a RV dominance in the newborn period, and which gradually changes to the LV dominance to the adult in the adult life. So by the 3 years of age, the child's ECG resembles almost that of adults. The age-related differences in the ECG basically reflects the age-related anatomical difference because the RV mass is more during the newborns and during infancy. Because in the adult life or in the older children, the LV mass is 2.5 times of the RV mass, while during the neonatal time period and during infancy, it's almost 1 to 1, or even the RV mass is slightly more than the LV. So then that's why there would be some RV dominance on the ECG that you will see. So RV dominance on the ECG basically is expressed by the right axis deviation, meaning that with lead 1, you will see more of the S wave, and the AVF is upright, and you will see more of rightward forces, so mainly the tall R wave in lead V1 and V2, and then the deep S waves in lead 1 and lead 5 and lead V5 and V6. This one. So this is just only I was mentioning before. What is the difference? Basically, there's a RV mass is more during early life as compared to the LV mass. So if you look at that at birth, the RV mass is about 1 into 0.8 of the LV mass. By the 6 months of age, the LV mass is twice of the RV mass. So that's why you will see a lot of right dominance during early period of life, which changes gradually by about 6 months of age, is almost similar to that of the older children's ECG. So what are the differences in preterm newborns? Basically, preterm newborns creates low voltages of QRS complexes, low T wave voltages, less RV dominance as compared to the full term. And there's a little bit of a left axis deviation in the preterms, and because the heart rate is also very fast, there will be short PR interval, QRS duration will be short, and the QT intervals will also be short. So it will be shown later. How the ECG is performed. So if we look at that nowadays, obviously the ECG machines are very smart, even the portable ECGs, that tells you all the details, actually where exactly to put the electrodes, the limb leads and the chest leads, and also the ECG machines can give you the full report of that ECG, but you really have to see yourself, and sometimes you have to calculate the intervals, like the QT intervals. It's very important that you have to calculate by yourself. So you really need to understand the ECG paper as well. So you need to look at that. Actually, when you're looking at the ECG, you have to look whether this is the standard ECG. ECG has been standardized or not. So ECG paper normally runs at the 25 millimeter per second. 25 millimeter per second means that in 1 second, there would be five boxes basically. So each large square basically has got the 5 small squares. So each small square is about 1 millimeter. So if there are 5 large boxes, and that happens in 1 second, so meaning that one large box will be about 0.2 second, and one small square will be about 0.4 second. And in terms of the calibration, so it will be normally calibration is about 10 millimeter per 1 millivolt. So you have to be careful when you're looking at the ECG that is not been half standardized. So otherwise you will miss a lot of findings. ECG leads. So there are about 12 ECG leads, which we know. There are 6 limb leads and the 6 precordial leads. Out of the 6 limb leads, lead 1, 2, and 3 are the bipolar leads, and the augmented limb leads and the chest leads are basically unipolar leads. So the limb leads basically gives you the more information from the frontal projection, meaning that from superior to inferior and right to left forces, while the precordial leads V1 to V6 provides the information about the horizontal plane, reflecting forces that are right to left or anterior to posterior. So this is just to tell you that there are 2 types of leads, bipolar leads and the unipolar leads. As I mentioned before, the bipolar leads 1, 2, and 3 are bipolar leads. So I've got the positive and the negative electrodes. So lead 1 will have the positive electrodes towards the left side, and that's the negative electrodes, and lead 2 will have the positive electrodes towards the left leg and the negative towards the right arm, and lead 3 will have a positive electrodes towards the left leg and the negative towards the left arm, basically. So lead 1 is the voltage difference between, as I said, between the left arm and the right arm, and it's basically directed towards the at an angle of 0 basically, while the lead 2 is a difference between the left leg and the right arm electrodes, and is directed towards the left leg at a 60 degree, while the lead 3 at 120 degree. So you will see these angles, what I'm trying to describe now, we'll see it later when I explain a little bit more. So the unipolar leads basically have got the single positive electrodes and utilize the combination of other electrodes, as you see here, as a negative electrode. So augmenting limb leads, AVR, AVF, and AVL, view from the vertical plane, and the precordial leads, V1 to V6, view from a horizontal plane. To understand more or to remember the hexaxial system, that is, then it becomes very easy as a logically to interpret the ECG, especially to understand the heart electrical axis on the frontal plane. Hexaxial system is made of by 6 limb leads. You can see lead 1, 2, 3, and then AVL, AVR, and AVF. So there are 6 limb leads, and the lead 1 and the AVF, they cross at the right angle, so that makes about 90 degree angle. So between the bipolar leads, lead 1 and lead 2 and lead 3, there is about 60 degree angle between them, and each limb lead has got 30 degree angle. So basically in this system, as I said, that the lead 1 and AVF cross at right angle at the electrical centers. And the bipolar leads, lead 1 and 2, they are clockwise with a 60 degree angle between them. The positive poles of the augmented limb leads, AVR, AVF, and AVL, are towards the positive right shoulder, positive left leg, and the positive and the left shoulder. So this hexaxial system will give you more, or if you understand it very well, then it becomes very easy to calculate or to look at the heart axis. So this is basically what is the same what I described before. The hexaxial system is made up of 6 leads, as I said before. This cross at the right angle, I've already mentioned this before. The positive pole of the lead 1 is labeled as 0 degree, and the negative of that is about 180 degree. So how to record or how to read the ECG basically. So there is a systematic approach, and that is basically is the same for the neonates as well as for the adults, for the older children. So basically, if you remember the sequence, or if you just follow your own sequence, then obviously you won't miss anything. So first of all, you have to look at the rate on looking at that ECG. Again, when you're looking at the rate, you have to look at the speed of the paper, which speed that paper has been running, and then rhythm, axis, QRS axis, especially P axis and QRS axis, and then the intervals, PR interval, QRS duration, as well as the QT interval, which is more important, P wave amplitude and the duration, and the QRS amplitude and the RS ratio, basically, that will tell you as the child goes from neonate to the few months to 6 months to later on, and this RS ratio basically changes because the RV dominance changes towards the LV dominance. And you have to look at the ST segment and some T wave abnormalities, especially T wave I'll mention in the during neonatal period, time period is important. So looking at the heart rate, as I said, that you really need to understand the ECG paper. And there are there are different ways basically to calculate the heart rate. And these are all based basically as on time scale of the ECG paper. So as I said, that the ECG paper runs at the speed of 25 millimeter per second. So this I've already explained to you. So one simple way is basically is that if you look at the count the number of the large division, basically the first two division, if the two RR intervals, the two RR complexes are falling next to each other, meaning from one bigger box to another bigger box, basically that rate will be about 300, meaning that because in 1 minute, the ECG paper will be running at the 1500 millimeter, and in one bigger box is about 5 millimeters. So if you divide that by 5, you get a rate of 300. And similarly, if the two RR complexes are falling to the two boxes, then obviously you have to divide that by by 10. So that will give you rate of 150. Or you can look at basically the time, measure the RR interval in seconds, basically, and then divide 60 by the RR interval. So that's what I was explaining that. So this is one larger box. So if one R wave is there, the second R wave is there, that completes one cardiac cycle. So that will be rate of 300. If one R wave or the complex is there, the second one is there, that rate will be about 150, so on 175. Basically, it's just because you know that at what speed the ECG paper is running. So because we know that the 5 larger box and each one large box is about 0.2 seconds, 5 larger box will be about 1 second. So it's a very simple way of remembering, instead of dividing the things, so basically just remember it like that: 300, 150, 175, 60, 50. So that's how you calculate the heart rate. So this is just only give you the examples of the same. Basically, there are 5 large squares, meaning 1 second. So you just have to look at that, how many in 5 large boxes to 1, and then you have to multiply with that 60. So the heart rate during neonatal time period, obviously it varies from 90 to 180, but it's around most of the time what we see is about 150 to 160. Newborn is a normal heart rate. Up to 180 or even 190 is also normal. And as the age progresses, the heart rate decreases, although the range can be quite variable. Rhythm. So first you have had a look at the rate, and then you have to look at the rhythm, basically. On looking at the rhythm, basically, you first have to look at the RR interval. Or are these RR intervals regular? Yes, these are regular. Once they are regular, then you know that this rhythm is regular, but we still haven't decided about whether it's a sinus or it's non-sinus. Then you have to look at the P wave. So there should be a P wave before each QRS complex. So you know that there is a P wave before each QRS complex. Now you have to look at whether this P wave is actually coming from the high right atrial region, meaning that the P wave axis is normal. So just only look at the lead 1 and AVF. If there are positive P waves in lead 1 and AVF, that tells you that the P wave axis is normal. So looking at the RR interval again, this is regular. Looking then at the P wave, yes, there is a P wave, and if the P wave axis is normal, that rhythm is going to be normal sinus rhythm. Then looking at this ECG, is that a RR interval is regular? No, it's not regular. So meaning that rhythm is not regular. It's basically arrhythmia. So normal rhythm is sinus rhythm. So this is the arrhythmia, basically. You see that RR interval is normal. Then you have to look at the P wave before each QRS complex. Is there a P wave before each QRS complexes? Yes, there is a P wave before each QRS complex. Then you have to look at the P wave axis. Is that the upright P wave in lead 1? Yes, there is a upright P wave in lead 1 and then in AVF as well. So meaning that P wave axis is normal. So, but the rhythm is just only has got the arrhythmia. So this is basically an example of the sinus arrhythmia, which is more common in slightly older children as compared to the neonatal time period. But you have to remember that you can see the irregular rhythm, but which actually is a sinus. So then looking at that ECG, this is one of the neonate. Is it regular? Is it sinus? Is it the same again question? So look at that RR interval. Yes, it is all looks like regular. Is there P wave before each QRS complex? Yes. Is it upright P wave in lead 1 and AVF? Yes. So this is normal sinus rhythm. So obviously rate is a little bit faster. It's about 180. So this is a neonate. If you're looking at small, little bit older child, so that is basically a sinus tachycardia. So look at that ECG. Is that ECG is, the QRS complexes are regular? To me, it doesn't look like regular. So look at that. Then look at the P wave. There are P wave before each QRS complexes. Actually, they're not 100% sure because it looks like there are more than one P waves. And you can't see basically the axis properly as well, but there are definitely, this is P wave, this is P wave. So you see more P waves than the QRS complexes. Basically, this is like a flutter. So just trying to give you an example that how you see rhythm as a regular rhythm or an abnormal rhythm. Looking at this ECG, is this ECG has got a regular or a normal sinus rhythm? Look at that QRS complexes. Are these regular? Yes, these are regular. Then we look at the P waves. The P wave is there upright. The P wave is there is upright. So it has to be a sinus rhythm. But then when I'm looking at the rhythm lead, I see that there are actually inverted P waves. So there are most of the time, the axis of the P axis is normal, but there are abnormal or the inverted P waves in the same lead. So this is basically is called the wandering pacemaker, which can be obviously you have to rule out the atrial tachycardia in those, but it can be in otherwise asymptomatic children. And this is ECG basically tells you again this is a regular rhythm. And then look at the P wave before each QRS complexes, there are P waves, but then look at the P wave. P wave is upright there, meaning in that direction. And then looking at the AVF. Sorry, this ECG is a little bit blurred, but you can see that this is an inverted P wave. So meaning that the axis is in that quadrant, higher left upper quadrant, which is basically is the lower right atrial part. So this is a ECG which is coming from the low right atrial rhythm. And sometimes it can be normal. So coming back to the same, what I mentioned, basically normal sinus rhythm is characterized by the P wave preceding each QRS complexes and a normal P axis between 0 to 90. In normal sinus rhythm, the PR interval is regular, but does not have to be a normal interval as it happens in the first degree heart block. The PR interval is irregular, but obviously it's not normal, it's prolonged. The SA node is located in the upper part of the right atria, as you know that, so that the depolarization is from right upper part to the left lower part, so creating that axis. Some atrial rhythms may have a P wave before each complexes, but that may have an abnormal P axis, as I shown you in the low right atrial rhythm or in the wandering pacemaker. So how to look at the QRS complex, QRS axis basically. So the simple way of remembering or just looking at the ECG to see that which axis actually is that. So you have to just look at that 4 quadrants. So in that quadrant, we know that lead 1 is in this direction, AVF is in this direction, okay? So you have to just only look at the only 2 leads first to decide about which quadrant is that. So if the lead 1, which is positive in that direction, basically, if that has got the positive QRS complex, I know that axis is going to be in this direction. Then looking at the lead AVF, if it's positive QRS complex is in that AVF as well. So that positive of the AVF is downward that way. So I know that the axis is going to be in that quadrant. Now to find out what exact axis would be, so a simple way of remembering is that if you look at the highest amplitude of any limb lead, so whichever lead has got the highest amplitude of the QRS complex, usually that is the QRS axis of that ECG. Or the other way is just looking at which lead has got the ecophasic QRS complex and the exact axis is perpendicular to that lead. So sometimes it becomes very difficult to remember exactly what angle was that. The simple way is that basically looking at that, deciding about the quadrant, and then obviously looking at the highest amplitude. So that lead will have exactly that QRS axis complex. So looking at that, number 2, basically lead 1 has got the positive, so it's in that direction. Lead AVF is negative, so it's going to be upright direction. That means it's going to be in that quadrant. So third example, so looking at the basically the right axis. So looking at the lead 1, so it's negative, so it's going to be in that direction. AVF is positive, it's going to be in that direction. So that's the quadrant of that QRS axis for that. So in that, both are negative. So that's lead 1 negative, AVF negative up there. So that is the extreme right axis. So normally in the newborns, basically, so that is the area where the axis would be. And obviously, as the child gets older, the axis changes from right to left. So on the QRS axis, as mentioned, so these are the leads basically on the frontal plane. So that will tell you about the AVR, lead 3, AVF, and AVL. Basically, that will give you, AVR 3 and AVF will give you the RV forces. On the chest leads, lead 1 and V2 will give you the RV forces. And on the limb leads, basically the 2 lead AVR 1 and AVL will give you the left LV forces. And on the chest leads, V5 and V6. So if you just have got that concept, then it becomes easy to looking at the QRS axis, as well as looking at the whether these are RV forces or whether these are LV forces, meaning that the left ventricular hypertrophy or the right ventricular hypertrophy. So this is what I've mentioned before. For determination of QRS, we use 6 limb leads. Basically, this is the repetition of what I have mentioned to you before. People use that, they find a lead with the ecophasic QRS complex and the QRS is perpendicular to that lead. To be honest, that becomes sometimes difficult to remember that. A simple way is just only looking at that, which lead has got the highest amplitude. So that exactly is that axis. So QRS axis at different ages, which I've already mentioned to you before, during 0 to 1 days, basically it's from this area to that area. And then obviously it's generally, it just keeps moving as the child gets older. By the age of 1 to 3 months, it's basically anywhere between there to there. And then later on, it moves to that direction, basically up to that. So this is the ECG of the 1-day-old, just giving you an example. This ECG of 1-day-old neonates. So looking at that, the axis and whether they are actually RV forces or not. So look at that lead 1. Lead 1 is mainly in negative, so it's going to be the left, right lower quadrant, or right quadrant basically, and then look at the AVF. AVF is mainly positive, so it's going to be downward. So it's basically the right lower quadrant, and then just look at that. This obviously in the newborns and in the during first few days or few weeks of life, mainly they are the RV waves up there, but in the neonate, in newborn, there will be upright T wave as well. This is a normal findings. So this is normal ECG for that age group. And the exact axis I was mentioning to you, so lead 3 has got the highest amplitude. So basically that exact axis for that neonate is about 120. This is the 2 weeks old neonate. So exactly looking at the axis again. So it's again is the right axis. We know that this is normal for that age. And then look at the T wave in V1. So this is a downward. So it should be downward because the T wave, upright T wave, is there during first 7 days of life. So it's very important to remember that. So after 7 days to 7 years of age, the T wave should be downwards. So this is basically the normal ECG and the normal axis for that age. Looking at the 5 months old, so see how these things are moving. It's moving more towards the left axis. So, and then the RS progression has been happening. So initially there were more S waves. Now you see the more R wave in V5 and V6, and obviously you see some S waves as well in V1, not in the CC. So coming back to again that normal QRS axis basically varies with the age, and usually have got the right axis deviation as compared to the adults. By the age of 3 years, QRS axis approaches almost to the adult, which is of plus 50. QRS axis in normal premature babies basically ranges between anything between 65 to 175. So QR axis, left axis deviation is present when QR axis is less than the lower limit of normal for that patient. So you have to remember that, that range. A left axis deviation basically happens in the left ventricular hypertrophy, left bundle branch block, anterior hemi block, AVSD, VSD, basically VSD will be biventricular hypertrophy, tricuspid atresia, and WPW as well. I'll show you some of the examples on the ECG on this one. The right axis deviation is present again when QRS axis is greater than the upper limit of the normal for that age. So meaning that basically, so if we look at that, the upper limit for that, the newborn of QRS axis is about 180, and if it goes to the right upper quadrant in that quadrant, so that is basically right extreme or the northwest axis. So that's not normal for that neonate. So right axis deviation will be present in the right ventricular hypertrophy or right bundle branch block pattern, and also a lot of other congenital conditions like, for example, severe pulmonary stenosis, and also in the neonates like chronic lung disease. Okay, so northwest axis is present in the AVSD, which is northwest axis is basically right upper quadrant. So northwest axis is present in the Noonan syndrome, very typical that happens in that. So looking at that ECG that shows you right ventricular hypertrophy, I will say right ventricular hypertrophy, because this just look at that axis mainly negative, and so it's in the right lower quadrant, and then look at that the R forces in the V1, they are quite tall. So in the neonate, basically anything more than 25 during first week of life, more than 25 millimeters, that's tell you about the right ventricular hypertrophy. Obviously, this is not a neonate, but it's a little bit older child. And then look at that T wave. T wave, as I said to you, is only positive during first week of life or after 7 years of age. So T wave upright gives you the indication that this is the right ventricular hypertrophy. And then look at the RV, or the R forces in V1, V2, and then look at the S forces in V5 and V6. So basically, this tells you about the right ventricular hypertrophy. So this ECG gives you examples of, look at that axis again. So lead 1 will be in that direction, we know, and then looking at the lead AVF, so this is negative, is going to be in that direction. So meaning that that is the quadrant of that. So, and then look at that, the highest amplitude of that. So that could be probably is in the either in the lead one or the AVL. So it's going to be about -30 excess of that. So basically, this ECG shows you about the left axis deviation, and then look at the the S wave in V1, V2, and then there are R wave mainly predominantly in V5 and V6. So this is basically left axis deviation with some left ventricular hypertrophy. And looking at that, the p-axis is calculated the same way as I said to you. Normally, it starts from the right upper region. Mainly, that is the normal quadrant of that p-axis, anything between 0 to 90. So if the P wave is positive or the upright in lead 1 and negative in AVF, it will be in that quadrant. That is right lower right atrial region. So if it's in that direction, meaning positive in the AVF, negative in lead 1, so that will be high left upper quadrant, and this quadrant will be lower left atrial region of that P wave. So this is the same ECG which I've shown you before. Basically, it's telling you about the low right atrial rhythm. It's positive in lead 1 and negative in AVF. So it's the low right atrial rhythm in that quadrant. T-wave axis is basically determined by the same method as the QRS axis. In normal newborn children and adults, T-wave axis is usually plus 45 or anything between 0 to 90. T-wave must be upright in lead 1 and AVF. T-wave axis outside of normal quadrant is seen in severe ventricular hypertrophy with strain or the ventricular conduction abnormalities or myocardial dysfunction of metabolic or ischemic nature. T-wave is upright. That's what you have to really remember, that T-wave is upright in V1 from 1 day to 7 days of life, but it should be inverted after that, and then it becomes positive after 7 years of age. But it should be really should be upright. So yes, just messing up. So it should be inverted in there, and then after that it should be upright after 7 years of age. And looking at the intervals, there are 3 intervals. So PR interval from the beginning of P waves to the start of that QRS complex, QRS duration, and then the QT interval, basically from there to there at the end of the T wave. These are the important intervals you have to remember, because that can tell you different abnormalities. So normal PR interval, we know, varies with the age and heart rate. If the heart rate is more, the PR interval will be less. So as the heart rate slows down, the PR interval increases. It's longer in older children because the heart rate is low. The normal PR interval is anything between 0.1 to 0.16 second, meaning that 3 to 4 small spares if looking at the ECG. So, but the prolonged PR interval will be more than 0.2 second, and it's usually seen in digital toxicity, ASDs, or Epstein anomalies, or in first degree heart block. So this is ECG. Just looking at that, just eyeballing it, the only thing that picks up is basically a prolonged, looks like prolonged PR interval. So this is just to show you an example, is more than 0.2 second. Otherwise, it's normal in an older child. So shorter PR interval is seen basically in the pre-excitation syndrome, like WPW, that will have the prolonged QRS duration as well, or Long-Guillain-Levine syndrome that will have a normal QRS duration but short PR interval. Myocardiopathys like Duchenne muscular dystrophy or Friedreich's ataxia. Otherwise, in normal individuals, variable PR interval, as mentioned to you, happens in bending pacemaker and Banky-Bax phenomena, of which type 1. So this is an example of WPW. You can see that the PR interval is really short, and there is a slurring of that that delta wave, basically swelling of the QRS complex, and the QRS duration is longer than normal in this one. This is Long-Devine syndrome. Let's look at that P wave, PR interval. PR interval is very short, but then look at that QRS duration. QRS duration is normal. There's no as such delta wave, but there's a normal QRS duration with a short PR interval. Venting pacemaker, as shown you this ECG before, will have otherwise normal axis, but actually the P wave axis keeps changing in almost the same lead. Variable PR interval. So that's basically, if you look at that P wave, that the interval increases there, increases further there, then you have got the drop speed. So this is basically is a Mobitz type 1 or Wenckebach's phenomena. And looking at the QRS duration, the QRS basically duration tells you about the ventricular depolarization. QRS duration is shorter in newborns, increases with age, and a prolonged QRS duration basically happens in right bundle branch, left bundle branch block pattern, WPW as mentioned to you before, or interventricular block, which happens in hyperkalemia, or in ventricular arrhythmias like PVCs or the VT, or sometimes, and also in pacemakers as well. So I'll just show you some of the examples of that. So this is an example of right bundle branch block pattern. So see that QRS duration is prolonged, and that is the RSR pattern in lead 1. So that's the prolonged QRS duration. This is an example of the left bundle branch block, and then see that all this QRS duration is prolonged, and this is basically a left bundle branch block. Or WPW, as ECG you have seen before, you see that prolonged QRS duration, but then obviously you have to look at the other features as well to see that delta wave, that QRS duration or the QRS duration is prolonged because of the delta wave. In the PV, this is a normal QRS complex, P wave. QRS complex is no P wave. Then you see the broader QRS duration. So these are just the ventricular ectopics. These are normal QRS complex, normal, and PVC. So just showing you the prolonged QRS duration. In the VT again, so you see that there's a left bundle, left axis deviation, as well as the prolonged QRS duration, also very faster, heart rate. So this is an example of the VT. So if you look at that, the QRS duration is almost the same at every age, but it should be less than 0.1 second or less than 3 small squares. QT interval, the most important, because long QT, if someone has got long QT syndrome, so obviously that's a disaster. So it can lead to VT or torsade. So that's why it's very important to look at the QT interval. Even the ECG tells you, the ECG machine gives you the normal reading. You have to really calculate or look yourself for the QT interval. So how it is measured basically, it's because it varies with the heart rate. So you have to have a heart rate corrected QTC. So, a well-known formula for that. Basic formula QTC is equal to QT divided by RR square root. The normal QT interval for the age group during first week of life, the QT interval is a bit prolonged, 478. It can actually remain 470 for few weeks, but then from first week to 6 months is anything between 450 to 460, more than 6 months of age, 450. To be honest, otherwise there's no history, no family history. I normally take even sometimes a little bit more than 450 as a normal finding. QT intervals, long QT interval may be seen in long QT syndrome like Jervell-Nielsen syndrome, Romanov-Ward syndrome, or hypocalcemia, or diffuse myocardial disease. And short QT intervals is seen in hypothermia, or there are short QT syndrome where actually the QTC is less than 300 milliseconds. Just to show you the ECG of the long QTC, you see that how that QTC is really long. So just only eyeballing on any ECG, you know, when there is a long, so you just, catches your eyes that this is abnormal. So this is long QTC. And again, looking at that ECG, heart rate is quite slow, but then look at that QT interval. So you have to really calculate it. Even if you don't calculate it, you know it's going to be more than 500 milliseconds. Short QT intervals. So there are some short QTC syndrome. This is quite short QT interval, less than 300 milliseconds. P-wave amplitude, basically the P-wave amplitude and the duration. So amplitude as well as the duration, they are, normally they are less than 3 small square or less than 3 millimeter, in duration as well as in the amplitude. So this is just only to give you what it signifies the P-wave abnormality. So if it's more than 3 millimeter, that will give you the right atrial hypertrophy. If it's more than 0.1 second or more than 3 small squares, so that will give you the left atrial hypertrophy. If they're both combination up more than 3 millimeter that direction and more than 3 boxes that direction, that will give you biatrial hypertrophy. This is just to give you the example of the same. So it's a quite upright PE wave. So right atrial hypertrophy in that, and right ventricular hypertrophy as well. So T wave abnormalities in lead V1, as I mentioned to you before, you have to really remember that on that finding. Then what are the voltages criteria for the right ventricular hypertrophy and the left ventricular hypertrophy for the age? Basically, if you look at the right ventricular hypertrophy from 0 to 7 days of life, so R wave in V1 and the S wave in V6, if it's more than 37 millimeter, so that will be, the right ventricular hypertrophy for that age. And then you have to remember some of these figures. Obviously, just pure R wave more than 25 millimeter during first week of life, that is a right ventricular hypertrophy. So similarly, for the left ventricular hypertrophy criteria during this first 7 days of life, if it's the S wave in V1 or the R wave in V6 is more than 28 millimeter, 30 millimeter to be honest. So that will be left ventricular hypertrophy, and then is 35 millimeter, and then in the older children is about more than 50 millimeter indicator of the left ventricular hypertrophy. Obviously, you have to see the other features as well, the axis and everything. So this is just to give you the example of ECG of a smaller child who has got the left ventricular hypertrophy. So looking at that ECG, you really have to look at that. This ECG is half standardized. So obviously, so when you will be looking at that, the R wave, so it's not about, 15, basically, it's about 30. So that's what, that's why it's important to look at that, the scale of that ECG. So in summary, looking at the ECG, so you have to look at the ECG speed and the standardization, look at the rate, rhythm. So in a sequential analysis, basically rate, rhythm, axis, and then P wave, QRS duration, and QT interval, as I explained to you. And remember, in the newborns, we'll have a right axis due to the right ventricular dominance. And also remember that the T wave is upright from 0 to 7 days of life, and then it should be downward. An upright T wave after 7 days of life, before 7 years of age, implies right ventricular hypertrophy. Thank you very much. Any questions?
Thank you so much, Dr. Arajmand. It was such a very informative talk. Now I would like to ask participants to comment, or if they want to ask any questions, they can raise their hands. Any questions from participants?
Thank you very much, Dr. Arajmand. Sir, I have a question.
Yeah, sure.
Sorry, Dr. Sikandar Hayat want to ask a question. Dr. Sikandar, you can ask, please.
Assalamu alaikum.
You can, yes.
Ji, walaikum salam.
I want to ask about the first thing you have mentioned that we have to look. The first step is
Sorry, I can't hear you. Could you just speak loudly, please?
exactly measure the rate from ECG, number one. Number
Look
two,
at it. How to measure the heart rate?
yes.
Is that what your question is?
Dr. Sikandar, please repeat your question. I
Is
think
that
there
what your question is? How to measure the heart rate? Hello? Hello?
there is a connection problem.
I think he lost his connection. Yes,
Has-
this is his first question, Arjumand, that how
Yeah.
to measure the heart rate.
Okay. So basically, you know that what the standard ECG paper speed is. That is about 25 millimeter per second. Yeah. So in 1 second, obviously, that means there are 5 larger boxes. So if you just look at that, yeah. So in 1 second, there will be 1, 2, 3, 4, 5. Yeah. So those 5 boxes, basically, that's what the ECG speed has been running. So meanings that there are 25 millimeter. So in one minute, basically, if the ECG is running as 25 millimeter per second, there will be about 1500 millimeter. Yeah. So if one QRS complex is there and the other QRS complex is there, simply we are dividing that because there are 5 millimeter in that one. Yeah. So we're just dividing that 5, 1500 by 5. So that will give you the heart rate of 300 beats per minute. So if you just look at that, if the one QRS complex is there and the next cycle is happening there, so meaning that there are 10 millimeter, yeah? So we know that ECG runs at 25 millimeter per second or 1500 millimeter in 1 minute. So just divide that 1500 by 10, that will give you the heart rate of 150. So just remember that. First, if it's up there is 300, then 150, 100, 75, 60, 50. So that's how basically it comes. Basically, it's based on the the ECG speed and also the duration basically.
Yeah.
We know that each large box is about 0.2 second or one small box is about 0.04 second. Does that answer
Yeah.
the question?
Yeah, I think so. Sikandar is not online, but I think so. You explained it. Arjun, can you talk about the involvement of EKG during the resuscitation of newborn? Because this is the recommendation from the last update, and this update they are very much into it. That if you have the facility to put the ECG leads as soon as possible during the resuscitation. What is your comment on that?
Yeah, I mean, obviously, if you're resuscitating, to be honest, if you're resuscitating any child, even a newborn, you should have the ECG. Without having an ECG, how can you resuscitate a child? So you should have, the ECG, or at least, on the monitor or on the defibrillator, basically, you have got some sort of a rhythm read happening. Otherwise, how can I resuscitate? How would I know that? What is
Actually, what I am asking, because of course the pulse ox is going to be there, but and they have the leads also. But I am talking about the real time ECG too.
No. I mean, I wouldn't say that 12 lead ECG. 12 lead ECG is going to be very difficult, so it's not going to be possible. Obviously, you have to have some sort of a rhythm lead, basically. Yeah. So in the rhythm lead, obviously, you need to know that actually if what's been happening during any resuscitation, if child might have some sort of arrhythmias. That child, for example, is in SVT or in atrial flutter and in a decompensated state. So that's why the child was so collapsed. So when you're resuscitating, you don't know. So obviously, if that child is in shock, and you haven't got an ECG or the rhythm strip, that could just be only in shock due to the SVT for longer period of time. So you just, correct that or give a shock to that child, so the child will be fine, or will come back not fine, basically. Does that answer question or not?
Yes, I understand, but the problem is this, that they are recommended that if you put the real time ECG, not the 12 lead, but just the limb leads.
Just the limb leads, just the limb lead, basically. You really need to have a look at the rhythm, basically.
Rhythm and also they are saying that the pulse oximeter is not that much efficient in assessing the rate of the baby who is sick enough. The ECG is much more higher efficacy of calculating.
That is true. That is true. That is 100% true.
Why that's the main thing. So now,
well, I mean, one is the rate. One is the rate, obviously. Yeah, but I mean, but at the same time, you with that ECG, some sort of a rhythm strip, so you will know that this is going to be like arrhythmia or or something else.
Okay, that's good. Thank you. Yes, Faraz, back to you. Vikram, you are asking some question?
Please, Dr.
Yes, sir. In developing country, usually most setup lack ECG machines, but they have monitors in their unit. They were monitoring babies with the ECG, without ECG. So if any unit doesn't have ECG equipment, and they want to check the rhythm rate or anything in the ECG, is the lead 2 from the monitor is relatively equivalent or less equivalent? Can we use that for some information related to rate, rhythm, or anything?
Yeah. In relation to the rate, yes. In relation to sometimes like a P wave axis, yes, you can. But obviously, to have the full information, you need to have a 12-lead ECG. But obviously, for the developing countries where this, if a country hasn't got, or in that unit hasn't got an ECG facility at all, then obviously, yes, from the monitor, you can have, just print out that lead 2 and then have a look on that, whether they say, sinus or, it's a normal rhythm or not, or there are some abnormalities. But really, if you wanted to know the, the ECG, you really need to have 12-lead ECG.
Okay, so as per my knowledge in units, there is not for limb, there are electrodes to be stricken against the legs on the medial side. Is it so, or any other things can be done for ECG in better way?
Sorry, say that again.
Electrodes to be applied at the limbs to capture ECG.
Yeah.
In contrast of adult, there is something which hold limbs, and some metal type things are attached to that, and that transfer voltage.
Yeah, but I mean, obviously, those are very difficult to put it in the little ones, in the neonates. So you really have got a really smaller electrodes, which you have to put it in there.
Dr. Sikandar, thank you, sir. Dr. Sikandar is back, and sir want to ask a question, and another participant also want to ask a question. Dr. Adnan is also want to ask a question. Dr. Sikandar, your questions were answered, and do you want to confirm what was the question? And sir will repeat again. Sir, please, can you answer again? Dr. Sikandar is back now.
No, actually, if we don't know to measure the heart rate without knowing the rhythm, we cannot get the exact heart rate if the rhythm is not normal. My comment was there. Number one. Number two, I want to comment on the Dr. Junaid's question about the value of ECG during the newborn resuscitation. Even in the latest NRP, as it is very difficult, even in very developed countries, they have not prioritized the EKG during the resuscitation. they usually focus on the measurement of heart rate and oxygen saturation from pulse oximeter in latest NRP. Or especially in our country, in developing countries like Pakistan, we should focus like more on the, like we can get the heart rate from the pulse oximeter or from the direct measurement from the stethoscope. So, and my third question from you, that what is the ECG effects in premature infants?
What is the ECG effects? Yeah. Sorry, say that again. What is the ECG effects in the prematures? Hello? 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 Can you hear me? Hello?
Sir, I think there is connectivity issue. Dr. Sikandar is still there.
I suspect he's asking what is the difference between a preterm ECG and a term in ECG or a infant. So he's asking whether there is any difference about preterm ECG.
There's a little bit of difference, as I mentioned, before, that I'll show you. I've got the slides up there. So basically, in the preterm newborns, the voltages of the QRS complexes are a little bit low voltage, and they're low T wave voltages, and everything is a little bit low. And the RV dominance is less as compared to the full-term babies. And there could be a left axis deviation in the preterms. And also the PR interval and the QRS deviation and the QT interval, all these are a bit short. So this is the comparison of the preterm newborns to the full-term newborns. So these are the differences. Now coming back to that, what we answer about that, the ECG. I mean, I don't know about in Pakistan or in developing countries, but surely I know that in UK and in other developed countries. So you really have got that ECG. ECG means that actually that child during resuscitation has got some monitor on there, not just only the pulse oximeter. There's a, you can see the QRS complexes on that during resuscitation. Any other questions?
The participant has a question.
Dr. Adnan wanted to ask a question. Dr. Adnan, sir, are you listening? Dr. Adnan, you can unmute your mic and ask.
Yes, now I can. I was unable to unmute it. Now I can. Thank you, Dr. Vikram. Yes, Doctor. First of all, thank you, Dr. Arajmand, for a comprehensive presentation. I want to take an advantage at the forum. There are about 6 or 7 patients since last 1 year. We have long QT syndrome, and we have to give them pacemaker. I have a suggestion here that for the Karachi people, or maybe for the others also in Lahore, why not we make a pathway where the people, the neonates who needs the pacemaker can be having a good system where they can be seen by like people like you, Dr. Arajmand, or the people here.
You mean?
Can you hear me? Yes.
Yeah, I can hear you. But you mean that children who have got the long QT and has got the pacemaker?
That's right. And
no, I mean that's a wrong treatment. That's a wrong treatment anyway. So it depends on, if you have got, if you have got like a heart block, or really you have got a bradycardia, then obviously you need a pacemaker. You really don't need a pacemaker for the long QT. What you need basically for the long QT treatment is a beta blocker. And then obviously in the other treatment, once you have got the beta blocker on board and it's well beta blocked, and child still has got the symptoms because of the long QT, like torsade or even VT, then the second line treatment is the ICD. It's not the pacemaker. It's actually it's a defibrillator, and obviously fitting a defibrillator in the neonate is almost impossible.
Yes, this is, I listened to you very carefully, and that was my point, that what actually happened, we have about 6 or 7 patients who were confused in the management, and then they come to us, we try to tell them, look, this patient is ICD, or you have to wait, heart rate should be less than 40, then we have to act upon it. So just I'm thinking that why not, if someone got this time of patient, refer to you or to us in a proper way, so that there will be a smooth delivery of the
Yeah.
treatment. This
Yeah,
was I want to take an advantage of the forum. Thank you.
Yeah, no,
Thank you.
no, that's a good suggestion. But obviously, I can tell you, I'm a pediatric cardiologist, but my main specialty or my main interest is actually in the interventions, even from the neonates up to the adult life. But these type of patients should be referred to the pediatric electrophysiologist, and you will probably have, I think, either is the next lecture or after that, there's a lecture by Mohsen, who is a EP, pediatric EP person. So he should be the one who should be looking after those children.
So, sorry for interruption. Dr. Mohsen is here. So, Mohsen, is there any possibility we can give the way to those neonates who need ICD at your setup, or any possibility we can make in future? You can unmute your mic. Mohsen, can you hear me? Mohsen, you can unmute your mic.
Hello.
Yes. I think Mohsen cannot talk at this time. So Dr. Mohsen is there at NICVD, and he had done a few days ago a pacemaker. So we can ask him for a possible ICD in neonate. Is it so or not? Hello? I'm visible? Can you hear me?
I can hear you, yes.
I think Sikandar, Dr. Sikandar? Okay, so Dr. Sikandar is not hearing at this time or any connectivity issue. So thank you very much, Dr. Arajmand. This was very nice, comprehensive lecture, which covered almost all things related to neonatal ECG, and it improves our understanding. So thank you very much. And our talk will be the next talk will be by Dr. Shazia Mohsen on coming Saturday. Thank you very much, all participants.
My pleasure. Thank you very much.
Arajmand.
Thanks a lot. Thank you. Bye.
Dr. Shauq, excellent presentation. You made a difficult thing into simple explanation. So I also learned a lot today. Thank you for your presentation.
Thank you very much. Thanks a lot.